Global Regional Coordinator. So while we are waiting for others to join, some announcements. So kindly visit our website at www.icuddr.org to access resources and links to the conferences, webinars, and workshop recordings. In a second, sir. Okay, so we invite everyone interested in applying for an international credential in addiction services to visit https portal.globalccc.org, check your eligibility, submit your application, or renew your registration. And uh, the Center for Credentialing is actually giving discounted renewal fees if you actually apply before the end of July. So we also want to invite everyone. So ICUDDR, in partnership with ISAM and NEPCOM, is documenting the impact of funding cuts to substance use prevention, treatment, and research, and identifying the support that is needed. Let your voices be heard by taking the survey. So we'll put the um, links in the chat later on. So you also can see the QR code. So the survey is available in two languages, English and Spanish. So translations for closed caption in various languages are available for this webinar. To turn on this feature, click the CC icon at the bottom of your screen, turn on translation, and select the closed caption languages of your choice. For questions during the webinar, please type them in the chat box and our speaker will address it at the end of his presentation. Lastly, we wish to inform you that this webinar is being recorded. So ICUDDR is pleased to have a very accomplished speaker for today's webinar, who is the Forsyth Medical Center Distinguished Professor of Economics in the Bryan School of Business and Economics at the University of North Carolina, Greensboro. He conducts research on the economics of health behaviors with a primary focus on the economic evaluation of behavioral health and workplace interventions. For nearly 3 decades, he has conducted economic evaluations of screening, brief intervention, and referral to treatment programs, and provided policy-relevant evidence supporting their ongoing development and adoption worldwide. He served as a co-investigator on the economic evaluation of the Robert Wood Johnson Foundation funded Cutting Back Study, one of the first alcohol screening and brief intervention studies in the United States. As the primary investigator of the SAMHSA Sprit cross-site evaluation, he led a multidisciplinary team of researchers to evaluate the implementation cost, outcomes, and impact of SAMHSA's screening, brief intervention, and referral to treatment grant program. So currently, he serves as president of the International Network on Brief Interventions for Alcohol and Other Drugs, also known as INIBRIA. So he also conducted economic evaluations of workplace program for 3 decades and providing evidence to policymakers and employers that has improved the health and well-being of workers worldwide. He also served as the primary investigator of the Data and Methods Coordinating Center for Phase 2 of the NIH CDC-funded Work, Family, and Health Network, and served as the cross-site evaluation director for the Young Adults in the Workplace initiative funded by Shamsha's Center for Substance Abuse Prevention. Currently, he is the economics lead for the Carolina Center for Healthy Work Design and Worker Well-Being. His publications have been referenced thousands of times, and his research has had a profound impact on public health by supporting the resources, allocations, decisions of federal, state, local, and workplace policymakers, both nationally and internationally. So, as I've mentioned, he is a very accomplished speaker, one like someone that we would like to emulate when we grow up in the profession. So, ladies and gentlemen, without further ado, let us welcome Dr. Jeremy Bray. Sir?
Thank you so much, Verna. Thanks for having me, everybody. Verna's going to help me keep track of questions as they come up in the chat. So please do put your questions there. And I will put in a plug now, and Verna will revisit it if I can remember at the end for everybody to consider joining INEBRIA, the International Network on Brief Interventions for Alcohol and Other Drugs. So with that, let me get started and talk a little bit about economic evaluation of screening and brief intervention. First, some acknowledgments. I have a lot of people to thank, and only a handful of them listed on this slide. So my apologies to everybody I've left off. But I would be remiss not to mention the SAMHSA expert evaluation team, especially Dr. Tom Babor. He was the lead of the RWJF study that Verna mentioned, and really a mentor to me in this field. Fran Del Boca and Bonnie Bakri, both on Tom's team at the time. Some UK collaborators I've been working with much more recently, especially Dorothy Newberry-Birch, Jennifer Ferguson, and Jillian Waller. And then several other colleagues over the years, most of them from my former position at RTI International, Arnie Aldridge, Carolina Barbosa, Alex Cowell, and of course many other people. You don't do these things on your own. It's always a team. Just funding disclosures over my career, and some of the research I'll present here has been funded by U.S. agencies, NIAAA, NIDA, SAMHSA, and Robert Wood Johnson Foundation. And then some of the work has been funded by the UK NIHR. So I thought I would start with a little background on screening and brief intervention, or SBI, just to make sure everybody understands what we're talking about. I assume this is well known to most people, so I'm going to move through this and in the next section of my talk relatively quickly. So again, please put questions in the chat. And in talking about this, I'm going to sort of talk about both SBI and SBIRT, which is screening, brief intervention, and referral to treatment. And a lot of the work I'm going to talk about has been SBI for alcohol, but some of it will be SBI and other drugs. So I'm going to sort of blur those lines. Again, we can come back to this when we do question and answer session. So public health motivation for SBI really focuses on the top part of this substance use pyramid, but not the very tip. It's really about that hazardous use band. And in alcohol, that would be drinking above recommended guidelines, but below levels of dependence or abuse, to borrow the old DSM-4 terminology. WHO's ICD-11 formally recognizes hazardous use as an ICD, which is distinct from harmful use and dependence, which are separate ICD-11 codes. And it's really that hazardous use, or maybe that lower level of harmful use, that brief interventions are intended to address. I have seen some research starting to look at brief interventions for dependence, or what we might think of as DSM-5 severe AUD or SUD. But it's primarily intended for the hazardous and mildly harmful use. Clinical evidence on SBI, particularly for alcohol, is pretty robust at this point. And we do need to recognize that there are several elements to the program. It starts with the universal screening program, and we have numerous validated tools to screen for a variety of substances. So we know we can identify substance use, alcohol use, illicit drugs, tobacco. We can identify that among patients presenting in healthcare settings and in a variety of other settings. There's substantial evidence on the efficacy, particularly of alcohol brief interventions in primary care. So we know a brief intervention will reduce use. The key here, though, something to remember, is it reduces use by a little bit. These are not big effects. They are significant and they are clinically meaningful, but they're not huge changes in alcohol use. And that's primarily because brief intervention, particularly for alcohol, is not an abstinence-based treatment. It is focused on reducing use, not eliminating use. Now, that's a little different for illicit drugs, and again, we can talk about that. But the evidence is strongest for alcohol, weaker for illicit drugs, and weaker or sparser, maybe is the better way to say it, in non-medical settings. And there is evidence to support a referral to treatment approach. And referral to treatment really started in the alcohol studies as referring people out of the study because they weren't eligible for the brief intervention. If somebody screened into a likely alcohol dependence level of use, then they should be referred out to treatment and not given a brief intervention. Under SAMHSA, that referral to treatment became integrated into a formal part of the overall program. And so some researchers started looking at referral to treatment approaches. Strongest evidence is really from hospital settings. I think in particular, some work Gail D'Onofrio has done of referring opioid users from emergency department into medication-assisted OUD therapy with great success. And the keys seem to be an immediate engagement with treatment. Some other studies have looked at using brief intervention techniques, motivational interviewing, to try to motivate treatment engagement. That's been less successful, but work continues there. Now, SBIRT has broad support from policymakers worldwide. In the United States, the Preventive Services Task Force, SAMHSA, both strongly encourage the use of screening and brief intervention, particularly for alcohol. In the UK, the National Institute for Health and Care Excellence recommends alcohol screening and brief intervention in medical settings. The WHO is promoting SBI worldwide. It is the F in their SAFER initiative, facilitating access to brief interventions. So there's a lot of support from policymakers to implement and sustain brief interventions, screening and brief intervention programs. With that said, there is still a lot of resistance from researchers and providers. Resistance from researchers really hinges around is SBI implementation moving faster than its evidence base, either in terms of moving into illicit drugs or recognizing that large-scale effectiveness studies are not finding the same effect that the tighter, smaller efficacy studies found. And I think that's where it's important to then remember that small effect that SBI has on alcohol use. Apologies for my cough. I've been fighting a cold for a while, and I think it decided to come back. So, providers also have been resistant to implementing SBIRT or SBI, largely arguing on time constraints or discomfort with the topic. A point I like to make with this is all of these arguments are fundamentally economic arguments against SBI. It's not that anybody thinks it's going to do harm, it's that they are arguing this may not be a good use of resources. So what we really need then are economic evaluations of screening and brief intervention. So let's talk about that a little bit. And here's a quick overview of economic evaluation methods. Again, I'm going to try to move through this pretty quick. On the left here is a figure that I really like. It's from one of my favorite textbooks on economic evaluation methods in healthcare. And what I like about it is it lays out the full range of things that an economic evaluation looks at. And then on the right, I've listed some types of economic evaluations. Now, cost analyses look at this first little part on the left that's labeled cost in this figure, but they also can look at some of the other parts, some of the consequences side that are easily monetized or maybe are naturally occur in monetary units. Cost effectiveness and cost benefit analyses, on the other hand, are going to look at everything as a comprehensive evaluation. Now, microcosting of program implementation, and I'm going to present some studies on that for screening and brief intervention. That focuses really on this part of this diagram that looks at the inputs to the healthcare program. So what are the resources used to deliver the program in question? If we think about screening and brief intervention, what we're saying is how much time does it really take a physician to deliver this so that we can answer that question, is it a good use of their time? The first way to answer that is to know, well, how much time does it really take? And so microcosting programs really dive deep into the resources going into the program. And in that way, they really are tied tightly into process evaluations or other more qualitative evaluation methods. Now, a cost offset analysis, again, looks at things in monetary terms, but it looks at the other side of the healthcare program. It's asking, what did the healthcare program do to save resources or reduce the use of resource use downstream? Primarily in healthcare, evaluation of healthcare programs, and particularly screening and brief intervention programs, what we tend to look at is healthcare utilization. Did we reduce future healthcare use by getting people to reduce their alcohol consumption by a few drinks a week? And I will talk about a few studies on that down the road. Now, a cost effectiveness analysis looks at everything. And that's the key to any economic evaluation method is it looks at both the costs and the consequences. It looks at all of this. Bear in mind, a clinical efficacy study is only going to look at the health outcomes. It doesn't look at the resources that go into it, and it doesn't look at this other value created. So an economic evaluation encompasses things that are beyond the scope of most clinical trials. What cost effectiveness does is it leaves the health outcomes, that health state, in its natural units. It does not try to monetize those. So it's comparing the health outcomes achieved to the total cost. That would be what we saw in the micro costing, and then what we saw in the cost offset combined. It looks at what was the total cost of achieving that health outcome. What a cost benefit analysis does is it monetizes everything. And that's where things get a little uncomfortable in the health arena when we try to start monetizing years of life and other health outcomes. As you all know, economists have done it, and we tend not to have too many qualms in doing it, but some people are not fans of that. So cost effectiveness analysis leaves the health outcomes in their natural units. So let's talk a little bit about screening and brief intervention now that we've set up that background. And I've put these figures up here in the top right corner to sort of anchor us in what we're talking about. So the first question I want to dig into is how much does SBI cost to implement? Before folks got on, Vernon and I were talking some about implementation science, and this really is an implementation science issue because what we're trying to do is monetize that implementation flow, that workflow. So how much does it cost to implement? Really not much, and that's one of the big draws to screening and brief intervention is it does not cost a lot to do. Now, a lot of microcosting studies have been done, particularly on alcohol screening and brief intervention, but also on illicit drug or a broader set of substances. I want to start by talking about a systematic review I did back in 2012 to sort of bring us up to, well, it's not current anymore. Time flies when you're having fun, but at least up to 2012. And that top table there is a table of results from one of the tables from that review. Something to point out is that the median cost, so looking at the midpoint of all the estimates we found in the literature, the median cost of screening was $3.80 per patient, which is pretty cheap. But if you can look at some of the fine print on that table, you'll see it can be even cheaper. In the RWJF study we did, We found that screening costs only 51 cents per patient. It really does depend on how you are screening. If your screen is letting patients fill a paper form out or perhaps using a tablet or something in the waiting room, it is actually really, really cheap to implement. If you're going to pay a medical professional to sit and ask questions, that's more expensive. But screening time takes only about 2 minutes. So it can be done relatively quickly. Again, that was the median point. Half of all the studies found it actually took less than that. Now, the cost of the brief intervention was just under $50. Now, these are 2012 US dollars. So, we do need to adjust for inflation and different monetary units. But we're still looking somewhere around $50, $55 to do a brief intervention, which is really not that expensive. And again, that was the median. Half of all the studies we looked at were less than that. I think more importantly is the median time of the brief intervention was under 14 minutes. Now that's really important for a couple of reasons. One, that doesn't sound like a lot of time, but it actually is a lot of time in most healthcare interactions. If you think about how long a doctor's visit should last, particularly an annual wellness check, you're probably planning somewhere between 30 and 45 minutes. So we're saying that the BI for alcohol is going to take half to maybe a third of that time. I think that's where some of the provider pushback is coming from, is that actually is a big chunk of time. It doesn't sound like much, but it can be. Now, of course, there are some interventions that are much, much shorter than that. And again, I go back to the Robert Wood Johnson Foundation intervention we did. That was only 4 minutes. Some others have been, 5 to 6 minutes. So it can be a lot shorter than that. And systematic reviews of the effectiveness of brief intervention show that you actually don't get much more effectiveness from a longer intervention. You do get some benefit from a second intervention, so a follow-up visit, but making that each of those visits longer doesn't really help a whole lot in terms of reducing drinking or substance use any further. So I think that the BI could be made shorter and that could be helpful. With that, the other big point, though, I want to make about that being about 14 minutes is, in the US at least, that is shorter than the minimum length needed for reimbursement, which is 15 minutes in the Medicaid HCPCS codes for alcohol brief intervention. So even though that's short, there seems to be this push among policymakers to want it to be at least 15 minutes, and I'm not really sure why. Now, another study I want to point out is this Cowell et al. Paper. That's a study we did off the SAMHSA SBIRT evaluation. So those brief interventions are for more than alcohol. One of the things we've learned over time is when you're looking at short duration activities, like a 2-minute screen or a 4-minute brief intervention, you really need to be precise on the time. If you ask people how long does your screen take, and they say, oh, 2 to 3 minutes, your screen is 50% more expensive if you use 3 minutes than if you use 2 minutes. And so it's really important to be precise about how long these short duration activities take. And we also have realized that people overestimate the time it takes them to do things they don't want to do, and underestimate the time it takes them to do things they do like to do. Time flies when you're having fun, right? So what we did for the SAMHSA study is we actually did a time and motion study. We literally we trained observers to follow the medical professionals around with clipboards and stopwatches and time how long each of the activities took. Now, in that implementation, there were a lot more activities than just screening and brief intervention. There was a pre-screen, which is I would definitely argue for particularly illicit drug use. The cost effectiveness of universal screening really does depend on the prevalence of the issue you're screening for. And so it made sense to do a very short pre-screen before going into a longer full screen. And then we had several levels of brief intervention. We had feedback, which almost every patient got. So that really wasn't a full intervention. Then, of course, we had the brief intervention, and we had something called brief treatment. If you're looking at the table 3 I've listed there, you'll see brief treatment was much longer. And that was more of a treatment that was more for people with dependence issues. But something I want to point out is we found the average time for a screen was just under 5 minutes, about 4.5 minutes. You'll see on the table we have the colons. 4:28 is 4 minutes 28 seconds. And so that was really useful to know. And these screens were primarily done with an interviewer, so a nurse or somebody else asking the questions, and they were screening for more than one substance. So that is still a really short amount of time, particularly when you consider that can be done while the patient is waiting. That doesn't have to intervene with the actual office visit. The average time for a brief intervention was just under 7 minutes. And that brings me back to brief interventions can be shorter than 15 minutes. And that's something that really is an advantage for them, but complicates perhaps funding of them through insurance reimbursement. Now, I do want to point out, though, that there may be more to it than just it doesn't take a lot of time to do. While it may not take a lot of time to actually do a brief intervention, it's not cheap to get started. You've got a lot of training to do, and you've got to alter workflows. So that is one of the things that we looked at both in the RWJF study and in a more recent study I did published just last year. This is one of the UK studies. What we found is that it costs quite a bit to train people to do screening and brief intervention. And you need to remember that's going to be a recurring cost. You can't train them once. You're going to have to train them perhaps once a year. Think about continuing education to make sure people are up to date on brief intervention. Another thing we noted, and again, this came out of that time in motion study I was talking about before, is how you staff the brief intervention really matters. Most of the SAMHSA grantees hired dedicated staff to do screening and brief intervention activities, which does seem to be the most efficient way to get a screening and brief intervention program up and running, is you need dedicated people to do it. Otherwise, it just gets pushed aside. But what we found is if that's what you do, then in fact, staff spend most of their time on things other than interacting with patients. That's this pie chart, so 2 sets of pie charts here that show the patient-specific expert activities only accounted for about 40% of a specialist shift time. They did spend a fair bit of time supporting evaluation. That wasn't our cross-site evaluation, that was local evaluation and ongoing monitoring and fidelity issues. We found about 15% of their time was just spent idle, waiting for patients to come to be screened and be intervened with. But then we also found they started doing other things besides expert. And in fact, what we found is that in sites where those specialists were more willing to do non-SBI or expert activities and then reduce that idle time, they were much more welcomed and supported in the clinic. The issue, of course, then becomes, do they get too busy with other things to stop and do a screening and brief intervention when the patient arrives and needs to be screened? So the bottom line on implementation cost is that SBI is cheap to conduct per patient, particularly when put in the context of other medical interventions. But it can be expensive to get started in how you staff it, how long the brief intervention takes. Some of these workflow issues will have big implications for annual operating budgets and long-run sustainability. So, does SBI save money? Now I'm going to look at some of these cost offset analyses and see, does it actually save the money that a lot of policymakers think is going to? And the answer to that is probably. SBI may reduce future healthcare costs, and notice I'm not very definitive on that. One of the first, again, this is off that Robert Wood Johnson Foundation study. One of the first studies I did on this issue found that no significant relationship between receiving a brief intervention and healthcare use at a 1-year follow-up. Now, what's interesting about that is we did find evidence that it reduced healthcare use in a lot of settings, in particular emergency room visits and inpatient days, primarily associated with emergency room visits. But the results were not statistically significant. And in a meta-analysis I did back in 2011, I found very much the same picture. We found that brief intervention was associated with an insignificant reduction in emergency department care, but also an insignificant increase in outpatient care. Now, this was a meta-analysis, so we couldn't really dig into the individual study data, and particularly not back in 2011. But I think that's suggestive that overall, we would reduce the cost of healthcare because emergency department visits are so much more expensive than outpatient visits. And to me, that pattern makes perfect sense with what brief intervention does. If you, particularly for alcohol, if you reduce hazardous use to lower levels, you're reducing the likelihood of injury and accident, which reduces emergency department visit. But you've also engaged the patient in more of a wellness perspective, and so that likely could incentivize patients to see their outpatient provider on a more regular basis, which is a good thing, but would be add some expense. Now, in a study published back in 2020, much more recent than the other two, Carolina Barbosa and I did this wasn't a meta-analysis, but it was a scoping review, so a systematic review process looking at healthcare outcomes, healthcare visits from SBI delivered in emergency departments. And again, a very similar picture. We found evidence that SBI delivered in emergency departments likely will reduce future healthcare use, but we could not really be definitive in that. So the bottom line on this one, keeping an eye on my time here, is that SBI likely will reduce future healthcare costs, but few studies actually show that definitively. And in reviewing the literature, I think we have two issues. One is that studies with strong designs, and so those are the well-designed efficacy studies, really don't have the power to detect changes in healthcare costs. The variance in healthcare outcomes, healthcare use, healthcare costs, that variance is much bigger than in the clinical outcomes. And so you need a lot more patients to detect an effect in healthcare costs than you do in drinking outcomes. And so the strong design studies just don't have enough patients to do that. Studies that tend to find significant effects, the problem with them is they really don't have great designs. They're mostly quasi-experimental. But what they do have are a lot of patients. They're quasi-experimental analyses of health claims data. And so they have plenty of patients, plenty of subjects to detect the effect, but then they have causal inference problems. And so they have sufficient power, but weak design. What we really need is a large scale study to really look at this, but that's expensive, and right now is not a good time to ask for research money. So, bottom line, is SBI worth doing? You know I'm going to say yes, but let me tell you why I'm going to say yes. Um, in a systematic review back in 2014, Colin Angus and colleagues, I was not involved on this study, they found that SBI is cost effective in primary care. And their conclusion is actually much stronger than that. They said they found overwhelming evidence that screening and brief intervention is cost effective. Alcohol screening and brief intervention is cost effective in primary care. Now, they were looking primarily at quality adjusted life years, or QALYs, as the outcome. And they had the NICE, National Institute on Clinical and Care Effectiveness. I always forget what NICE stands for, but the UK NICE has a threshold for that to tell you when something is worth doing, and I think it's around 50,000 pounds per QALY. Uh, Screening and brief intervention is well below that, always. So it is cost effective to implement. In a study we did also off the SAMHSA expert evaluation, we found that multi-drug expert, so the Angus review was alcohol. Now I want to look at more than alcohol. We found that it's more cost effective when delivered in emergency departments. And we also found that brief intervention was actually more cost effective than the more intensive brief treatment that was done as part of the SBIRT evaluation. So overall, it's really is a cost-effective intervention, particularly when compared to a lot of other things we do. You get much more health gain for much less money. Even though it's a small health gain, when you compare it to the small amount of money you're making, it is such a great value that SBI is definitely worth doing. So, bottom line is SBI is cost effective in reducing alcohol and probably other drug use. But given the small effects on clinical outcomes, a lot of that is driven by how cheap SBI is to conduct. Right? We are talking about small changes in substance use or alcohol behaviors, which then have downstream effects over somebody's life if those reductions are maintained. But really, we're talking about small improvements in health. But because they're so cheap to do, to obtain, SBI really is a cost-effective option. And then I've got all the references here, and Verna is going to send these slides out. Look at that. I wrapped this up with plenty of time for questions. So Verna will send these out as a PDF, so you'll get both pages of references. I did focus primarily on my own research. I hope you all don't mind, but there's lots more than just what I've done. So please go out and look and find things and reach out to me. Happy to talk. And front of that are the end of my slides. So I'm going to stop sharing and we'll open it up for questions.
Thank you, Dr. Bray. But before, so if you guys have questions, feel free to use the chat box. We'll read it to Dr. Bray. While we are waiting for questions, I also have a few. Would you like to invite people to join Inibria? Because like that's really a good.
Thank you. Yes. See, I told you I was going to forget that. I should have created a slide just on that. Yes, please. Inebria is the international network on brief interventions for alcohol and other drugs. It's a small professional society focused on brief intervention, and that's one of the reasons I really like it. In particular, when you go to our annual conference, you are rubbing shoulders with the original researchers in the field. Some of the biggest names there, and they are easily accessible. It's a great organization. It grew out of the World Health Organization study that created the original alcohol use disorders identification test, the audit, and was a natural extension of the European arm of that. We now are still strongly based in Western Europe, but very big North American and South American contingent, big growing group of researchers in Africa and in Southeast Asia. So I really encourage everybody to join. It's a great resource. And there are no membership dues. There's an application. Because there are no dues, we do vet people to make sure that everybody who joins actually has a real bona fide interest in brief intervention research. But it's, again, just a great organization.
Yes, and also like membership is for free, so join them. I put the link on the chat box if you are interested. Please do sign up. I did, so it's really good resources. So there's a few questions here, and I would also add my a few of my own. And if you guys have questions, we have sufficient time to address it all. Sir, the first question is like, in slum areas, how can one help people struggling with addiction using the screening and brief intervention model? So I think like for low resources country, so how can they help screening and how can screening and brief intervention help?
Yeah, in terms of helping people with dependence issues, you really should think of this as more of a prevention approach. However, we are doing some work right now with colleagues at Duke University in Uganda as part of their rollout of brief intervention nationwide through the WHO's SAFER initiative. I think brief intervention, beyond just being preventive, can really help connect people with use disorders along the full spectrum, including dependence, connect them with treatment options and with the treatment system. Again, I go back to, this isn't a low resource setting, but the work Gail D'Onofrio has done in Yale Medical Center, engaging people with opioid use disorder right in the emergency department, giving them their first dose of medication, opioid use disorder medication, right then and there, and then making an appointment with them for treatment. That is much more effective than some of the other referral approaches we saw in the SAMHSA expert evaluation. We called that a warm handoff. And the warm handoff between the general medical setting and the specialty setting is absolutely critical. And it's something that a screening and brief intervention program can facilitate and make happen. If you don't have that warm handoff, if you don't have somebody actually helping the patient get to treatment right then and there, then it becomes much more difficult. But I think that's something that SBI can do, and we have seen it do.
Thank you, sir. So there's a question about materials. So I posted the link there for World Health Organization related materials in screening and brief intervention. So I hope you guys find that helpful. In connection to what you mentioned about incorporating screening and brief intervention, whether in prevention or emergency medicine. So how challenging it is in terms of, you mentioned about the time component as an important aspect of screening and brief intervention, but how difficult it is to actually inform practitioner or like in the self-reporting, how do they differentiate the time allotment for screening and brief intervention to other activities integrated when they see patients or clients?
So that's a great question. So I think it goes back to sort of that perception of time and what they've been trained to do. Particularly again for non-dependent use. what we find time and time again is it actually does not take that much time of a of somebody with the authority over medical decisions. You know, somebody like a doctor, a nurse, you know, a healthcare professional, really doesn't take too much of their time to convince people that they should consider reducing their alcohol use. Now that is alcohol. Brief interventions for illicit drugs, we are still trying to find the best way to do that. We are finding some that are starting to have an effect. Um, my my gut tells me that we're going to find something very similar from marijuana in the U.S. as recreational marijuana becomes more prevalent. Um, that also will become something that is easier to reduce. I do think it depends a little bit on how physically addictive is the substance, which may be one of the reasons brief interventions for, in and of themselves, brief interventions for cigarette smoking, tobacco use are not as effective as they are for alcohol. Now, brief interventions for cigarettes tend to get combined with other therapies. Um, and sorry, Vern, I think I've drifted off the question. In terms of you know, provider time and their perception, I think the other thing we need to recognize is primary care providers are given so many things they're told they need to screen and intervene for in a variety of ways. There was I'm not sure study is the right word for it. I saw a paper many years back that suggested if a primary care physician did every preventive activity they were asked to do, it would take more than 24 hours in a day. It would completely fill everything that they had to do and would leave no time to actually address the issue the patient came for. And so that's back to my argument. It's an economic issue, right? The question is, what is the best use of their time in that moment? And even if a physician or a nurse does not have time to do a full brief intervention, I think we should absolutely screen for substance use as a normal part of health histories. We need to know what other substances do people have in their system before we prescribe them medications, before we can have any sense of how effective is the advice we're giving them going to be. Um, so that is something that I firmly believe, and of course I have come to this conclusion through many interactions with folks like Tom Babor who have told me this over many years. But I firmly believe we need to be screening for these substances, even if we don't know what to do about it. And then we can tell physicians you can do something about it. And here's what you can do about it. But use your best clinical judgment as to whether that's what this patient needs right now. I mean, if you look over their health profile and you see some heart issues, a history of cancer, high blood pressure, glycemic control issues, maybe prediabetes, and they're drinking more than guidelines, reducing their alcohol use is probably going to be a good bet, right? That's one of the things they can do to bring all those other things back into a healthier range. And so getting physicians to understand that and prioritize talking about alcohol and illicit drugs and honestly feeling comfortable doing it. All right. I mean, that's just something you should be able to talk to your patients about. Yeah, I reflect on my own visits to my healthcare provider. And anytime we get even some remotely close to an issue that she doesn't feel comfortable with, she makes a referral. You know, referral to cardiologist, you know, referral to dermatologist, referral to everything. You know, we need to be able to do the same thing. with this. And it doesn't have to be a referral to specialty care. It could be, you know what, I want you to talk to our health educator for a few minutes, and they'll give you some information about alcohol or drug use.
Thank you so much. My next question is something to do with what you mentioned with regards to starting like implementing screening and brief intervention can be costly, but it's cost effective in the long run, right? So
Hmm.
how do you convince policymakers to make the necessary investment for training people or integrating the services to the general healthcare?
Yeah. That is something we're struggling with. I think having these higher level policy organizations pushing it is really helpful there. With the particularly in developing countries, having the WHO pushing it through the Safer Initiative is very helpful. Again, endorsement from NICE in the UK and SAMHSA in the USPSTF here in the US. Those endorsements are really, really helpful. Um, and it's through things like that that the most successful screening and brief intervention implementations that I've seen have been done. I mean, one of the most successful is through the U.S. Veterans Administration. And the USVA just told its clinics, you will do this. No, we're not going to pay you. No, you're not. It's just you have to do it. And so that unfunded mandate was really, really effective in getting clinics to do screening and brief intervention. Very similar unfunded mandate was in level one trauma centers in the U.S. The U.S. College of Surgeons Committee on Trauma uh, requires for certifications at level one trauma center, the trauma center has to provide alcohol screening and brief intervention. And that was really through the work of Larry Gentilello, who saw the connection between excessive alcohol use and severe trauma and injury, car accidents, pedestrian accidents. And he realized the primary cause of most of the injuries that he was treating as a trauma surgeon were caused by substance use, by alcohol use. And that if you if you treat the trauma, if you treat the injuries, but you don't address the underlying cause, you're going to get those patients back again. So I think, that is one way to really push it out there. The other is through identifying champions, local people who see the value. That's the other thing we noticed in Verna as somebody doing implementation research. I'm sure you've seen this. You need a champion. You need somebody local who really is the cheerleader for this new program to keep it going. And one of the things I continually ask is, how do we create champions? We seem to always look for them and hope they naturally occur. But the question is, how do we go out and create a champion? When you're implementing a new program like screening and brief intervention in a primary care clinic, if there isn't somebody there who's going to be the champion, what can we do to create one, an effective one? I don't have an answer for that, but if somebody does, please let me know.
Thank you. I was about to sort of like follow up on that. Like you were it's a very good emphasis on how important the top-down approach is in terms of like integrating screening intervention into policies, mandating agencies to actually implement it as so that it becomes part of the culture, right?
Hmm.
Creating champions so that from bottom up approach, how do we actually have that person that sorts of push and motivate that? But
Yes.
a lot of the practitioners actually underestimate the value of screening and brief intervention. So, any last words on um, how do we make it like how do we make people see that that it's valuable and that it's a fundamental in all services?
Yes. Yeah. And I think the key there is showing. showing value in the areas that your audience values. All right. So, I do a lot of work on the cost offsets. Will it save healthcare dollars in the future? Which is very important to SAMHSA, U.S. Medicaid and Medicare Services, to the National Health Service in the UK, and these larger agencies. The individual physician doesn't really care that much about that, right? Yeah, on a grand society level, they do, like everybody else, but that's not why they're seeing patients. But that goes back to, if you then can point out to the physician, by the way, this patient of yours who can't seem to get a good night's sleep, ask them how much they're drinking, right? And if they're drinking, 3 or 4 a night, yeah, you know what? Try taking that down to one and see how well you sleep. And make sure you drink it before 8 p.m., right? Little things like that can actually then tie back to the intrinsic motivation of the healthcare providers. Yeah, and sleep may not be the right one for everyone, right? This is where we've got to understand that the broader range, but as research continues to expand on the harmful effects of alcohol, and we know harmful effects of other illicit drugs, I'll stay focused on alcohol because that's what I know best, but we know it impacts sleep. We know it increases cancer risk. It actually doesn't have the heart health benefits you think, and it might actually be harmful to some. It impacts your blood pressure, right? It impacts digestive, right? If you're having heartburn, maybe it's your alcohol, right? There's so many systems that alcohol impacts that I think we can reach out to physicians and connect to something that is meaningful to them.
Thank you so much. And Jeremy mentioned something very important, that sometimes, like, that heart benefit related to alcohol, because, like, we have to go back to the original study because it's for a particular population. It's a particular age, but we sort of, and that's part of how we, academicians, researchers, practitioners, sort of bridge that gap between research and practice, right? So not to take one piece of the research results and translate it to everyone. Again, we would like to thank Dr. Jeremy Bray. This has been a very good session. So we thank you for sharing your expertise with us. And just a final reminder, if you want to join Inibria, we put um, the link on the chat box. It will be there. We also invite you to take the survey so that we document the effects of the what we are experiencing right now in the field. You know how important it is, like, to continue services for substance use prevention, treatment, and research. And also, we also want you guys to, if you want to attend our future webinars, we will have one on June 17 with Dr. Richard Rawson and Dr. Cameron Nias for the global trend of stimulant use, and to with Dr. Brandon Gray and Dr. Dimitri Krupchanka. I have difficulty always pronouncing his surname, so I just call him Dimitri. It's going to be on July 8th on building competencies in substance use and mental health. So again, we thank you everyone for attending, and we hope that you have a good day. Jeremy, thank you once again.
Thank you so much, Vernon. Thanks, everybody. Have
Thank
a great day.
you. Have a
Okay.
great day, everyone. Goodbye.
Bye-bye.